Namaskar. A very good evening to all my respected CCI colleagues and seniors. And I would like to welcome you on to this very interesting webinar on the flu epidemic, which is currently going on. And all of us from all parts of India and the world are actually dealing with it either as a patient or as a doctor. We as chest physicians tend to see such cases much more frequently and tend to encounter these cases as the first line of defense that medical science has to offer. I would like to thank CCI for considering this very important topic and giving me, Dr. Ravi Dosi from Indore, an opportunity to moderate this very important webinar. This is a problem of such huge proportions that you can have 10 webinars on 10 consecutive days and still you will get thousands of audience. So there is no less number of patients and a very high number of queries regarding this particular problem. There are many issues that come to us in day-to-day practice, and we all need to discuss, learn from each other, and all of us will definitely agree to my one statement that no two flu patients are alike to each other. Even families which are affected are not alike to each other. So, discussing about this disease, which has been plaguing humanity for so many years, today I have a very interesting and highly academically acclaimed panel with me. But before going on to introduce my panel, I would like to thank Dr. N.H. Krishna sir and the CCI webinar team for holding this webinar today. We will be initially having two presentations followed by a very engrossing panel discussion. I would like to call upon Dr. Kumar Utsav to first go ahead with his presentation on influenza vaccines and diagnosis. Dr. Kumar Utsav is a senior chest physician from Varanasi, and he is also an entrepreneur, has his own hospital. So Dr. Kumar is the person to know when you get influenza in Varanasi. So go ahead, Dr. Kumar, please.
Thank you so much, sir. I'll begin my presentation now. Hello, everyone. This is Dr. Kumar Utsav. I am currently in the city of Varanasi. I am working with Agrim Hospital and a consultant pulmonologist in Samaria Multispeciality Clinic. Today, we are going to talk about influenza, emerging influenza strains, and vaccine development. Going through a flashback, when did influenza virus actually first time infect humans? Humans probably acquired influenza when they began domesticating animals like birds and pigs. The rise of agriculture and permanent settlements provided ideal conditions to trigger a flu epidemic. What is the earliest evidence of influenza? In his sixth book of epidemics, the great Greek physician Hippocrates described a highly contagious disease with flu-like symptoms. Modern doctors believe this may be the first ever reference of influenza. This happened in 1412 BC. La influenza. In 1357, people called an epidemic in Florence, Italy, influenza di freddo, which literally translates to cold influence. This may be a reference to the possible cause of the disease. Many astrologers in Middle Ages believed that the periodic return of the disease was related to the influence of heavenly bodies or influenza di stelle, meaning influence of the stars. First ever recorded flu pandemic was in 1580, started in Asia in summers, spread across Africa, Europe, Americas via seas. Total death toll is unknown, but it killed around 8,000 people in Rome alone. The deadliest pandemic ever was recorded in 20th century was 1918 Spanish flu pandemic. The 1918 Spanish influenza outbreak was caused by the new strain of the influenza A virus that started in birds, that is the H1N1. After reports in Europe, Asia, and United States, it rapidly spread across the world. About one-third of world's population was infected, and 20 million to 50 million people were killed. The average life expectancy in the United States dropped by about 12 years. On the right, you see the image of the Washington Times, September 27, 1918. It is a female wearing the mask. This is the first picture of the new mask adopted by Red Cross. On the left, you see a poster issued by the Provincial Board of Health about how to make a mask and how to prevent Spanish flu. So at that time, when there was no vaccine, no drugs to treat influenza, people got very sick very quickly. Hospitals were overwhelmed. Many communities imposed quarantines and closed churches, schools, and public spaces. The public used gauze masks to stop the spread of the disease. How do you control a deadly contagious disease in the era of mass transportation, crowded cities, and World War? Implementing social distancing, like what we did in the first wave of COVID. India got saved in the first wave of COVID by the judicious judgment of lockdown that led to better understanding of the disease and facing the problems when we are at least ready with the man and material how to manage a disease better and having some knowledge about it. Coming to the Asian flu pandemic and the Hong Kong pandemic that happened between 1957 to 1970. A Asian influenza A virus struck in East Asia in 1957, first reported in Singapore, then quickly spread to Hong Kong and then United States by summer. Death toll was around 1.1 million worldwide and around 116 in the United States alone. The rapid development of vaccine and availability of antibiotics by the time of 1957 limited the spread and death toll at that time. Hong Kong flu happened in 1968. It was a global outbreak influenza, but it originated in China, like our very own COVID virus. The virus was highly contagious, and in Hong Kong, 5 lakh cases were reported within 2 weeks. It quickly spread throughout Southeast Asia and reached the United States within months. Transported by soldiers returning from Vietnam, experts suspect that it evolved from a strain of influenza that caused the 1957 pandemic. Many exposed by the 1957 virus retained immunity against the 1968 virus. The pandemic killed between 1 to 4 million people globally. The swine flu happened in 2009, was first detected in the United States in April 2009 before quickly spreading around the world. Primarily affected children and young adults who had no immunity to the new virus. Around 60.8 million cases were reported, 12,500 deaths in the United States alone. Due to rapid response of the CDC and WHO, a vaccine was quickly developed. The first dose was administered on October 5 of the same year. Avian flu or bird flu, a type of zoonotic disease, infectious disease that spread from animals to people, first detected in the late 1800s in northern Italy, and throughout the decades, bird flu has been found in domestic poultry such as chickens around the world. The bird flu outbreak that is causing the virus, causing the majority of concern to public health, is an H5N1 virus, which is considered highly pathogenic avian influenza. In 2013, a different strain of the avian flu called H7N1 N9 was identified in 139 people in China. In the HPAI H5N1 virus that is spreading across the world, around the world right now, was first detected in wild birds in China in 1996. So, due to significant losses, around 50 million people died of the Spanish flu in 1918-1919 and 1919. So, great scientific research happened and discovery was done. In 1920, some scientists finally began to suspect that bacteria weren't the real cause of influenza disease, something else. And after much research, in 1933, scientists of National Institute of Medical Research in London isolated influenza A virus from the nasal secretions of infected human patients. This discovery would lead to innovation of inactivated vaccines in the late 1930s and 1940s. The development of first inactivated flu vaccine was led by Thomas Francis Jr. and Jonas Salk of the University of Michigan, and their vaccine used fertilized chicken eggs, a method still used to produce most flu vaccines. The first influenza vaccine was approved in the United States for military use in 1945 and civilian use in 1946. Eggs have been used to manufacture seasonal flu vaccine for over 70 years. The scientists developed the first trivalent flu vaccine that protect against 3 different strains of influenza, and today quadrivalent flu vaccines are commonly available and used in every flu season to protect against 4 different flu strains. The antiviral drugs like idoxuridine was the first antiviral drug to be approved. Since this scientific breakthrough, antiviral drugs have helped millions of people around the world. We have also used oseltamivir during last few years. In 1993, the first study is published demonstrating mRNA vaccination in mice. In 2012, multiple studies found that mRNA vaccine induced long-lived and protective immunity to influenza. That's it. Too much to discuss, too little time. I would end my talk here, and I would thank the podium of CCI for giving me this opportunity to speak to you all this evening. Over to you, Ravi bhai. Please take.
A very good evening to all my colleagues and seniors from CCI and all those people who are attending this webinar today, Thursday night. I would like to thank Dr. Utsav for your interesting talk and would like to begin my talk on the diagnosis and treatment of influenza in this particular flu epidemic. I would like to begin by thanking Dr. N.H. Krishna sir, Dr. Narayan Pradeepa, Dr. Ashish Dubey sir, Dr. Anil Maske, and the entire CCI webinar team of CVK sir, Shivani ma'am, Atri sir, and Kirat ma'am for giving me an opportunity to moderate and give a talk on this very important and relevant topic. Influenza, as we all know, has presented to us over the past few months in very many different ways. But the common presentations have usually been fever, running nose, sore throat, myalgia, malaise. Usually, mild patients don't complain of dyspnea and shortness of breath, but they do have loose motions this time. Some cases of complicated influenza presenting with shortness of breath, chest pain, tracheal tenderness, and CNS involvement, along with secondary dehydration, are also being seen. The manifestations of swine flu are multisystemic. They are neurological, cardiac, respiratory. In pregnant patients, there is increased risk of maternal complications. And in musculoskeletal, they have persistent myositis and rhabdomyolysis. This is in apart to our usual symptoms of fever, dry cough, nausea, vomiting, and myalgia, which is seen. The specimens which are used are nasal or nasopharyngeal swabs and oropharyngeal swabs, although throat swabs are not tend to be useful after 2 days of illness. We even go for bronchoalveolar lavaging and we transport these samples in a triple packing system. For lab diagnosis, viral culture in egg culture is the gold standard, more so with the increasing levels of neuraminidase resistance. RT-PCR is the best method for initial diagnosis. And for serology, in a research setting, antibody detection by hemagglutinin inhibition and the seroconvalescent sera comparison, although not at all indicated in a clinical setting, are also existing. Now, when should a clinician start antiviral? Well, the clinician should start antiviral in a case of suspected influenza, irrespective of the influenza vaccination history, who meet the following criteria. Persons of any age hospitalized with influenza, regardless of illness prior to hospitalization, OPD patients of any age with severe or progressive illness, outpatients who are at high risk of complications from influenza, like those with chronic medical conditions and immunocompromised patients, children younger than 2 years and adults more than 65 years, pregnant women, and those with 2 weeks postpartum period. Clinicians can consider antiviral treatment for even not so high-risk patients. If they have an illness within less than 2 days of presentation, those who are symptomatic household contacts of patients who are symptomatic or have been diagnosed with influenza, or symptomatic healthcare providers who are at high risk of developing the complications of influenza, which can be you and me. So be careful. For patients who are recommended to receive antiviral treatment for suspected or confirmed influenza, what should we prescribe? Well, the recommended drugs are those which are used everywhere, single neuraminidase inhibitors, either oral oseltamivir or where available inhaled zanamivir or intravenous peramivir. In India, as of now, we commonly have oral oseltamivir, which is available and is also recommended by the Ministry of Health and Family Welfare guidelines. Higher doses of oseltamivir don't carry any major advantage and have not been recommended. Clinicians should treat healthy, uncomplicated patients with 5 days of oral oseltamivir or other antiviral drugs. Longer duration of treatment can be given in patients who are having immunocompromise or patients requiring hospitalization for severe disease. in a patient with suspected or confirmed influenza, when should we think of bacterial co-infection? Well, we should think when we have a suspected or lab confirmed influenza patient who is presenting with a very, very severe disease like extensive pneumonia, respiratory failure, or sepsis, septic shock. We need to remember the new ARDS definition by which the role of AVG is not there. On the basis of SpO2 and the oxygen that you give, you can make a clinical diagnosis and suspect bacterial infection. We should investigate and treat that bacterial co-infection. And those patients are usually those patients who usually don't improve in 3 to 5 days of antiviral. Now, if a patient of influenza doesn't demonstrate improvement in the first 3 to 5 days, what do we do? Over the several epidemics, which we'll be discussing later, there have been several reasons. But of late, if you can see in 2009 and 2013, drug resistance has become a very, very important reason. So we need to keep that in mind. If a patient is more virulent, it will go and attack the lower airways more. And if it is less virulent, it will attack the upper airways more. We always should try to get a radiological imaging done. And at times, the other manifestations like cavitating disease, interseptal thickening can help us differentiate a presentation from the usual ground glass opacification, which we find. When should the testing be done for infection with for antiviral resistance? Well, patients who develop lab confirmed influenza while or immediately on prophylaxis, patients with an immunocompromising condition or evidence of persistent influenza replication or who remain persistently ill should undergo that testing. Patients with lab confirmed influenza who inadvertently receive subtherapeutic dosing as per dose, as per weight, and patient with severe influenza who do not improve with neuraminidase inhibitor treatment and have persistent replication. There has been a strong advocacy of various types of adjunctive therapy. Well, the guidelines of IDSA say that we should not administer corticosteroid adjunctive therapy for the treatment of adults or children with suspected or confirmed seasonal influenza, influenza-associated pneumonia, respiratory failure, or ARDS unless indicated for one other condition as per the sepsis guideline. Clinicians should not routinely administer immunomodulation in the form of immunoglobulin IV intravenous in adults or children, but the use of probiotics is now finding a little place. Antiviral chemoprophylaxis may be given in patients who are more than 3 months of age and at very high risk of developing complications from influenza. If they receive hematopoietic stem cell transplant in the first 6 to 12 months, post-transplant lung transplant recipients, clinicians can consider short-term prophylaxis along with prompt administration of inactivated influenza vaccine for unvaccinated children who are at high risk of developing complications if they are in contact. Short-term prophylaxis is considered for unvaccinated adults, healthcare personnel, children aged more than 3 months, and children. Clinicians can consider educating patients and parents of patients to arrange for this early treatment till they get vaccinated. The recommended drugs are neuraminidase inhibitors, particularly oral oseltamivir in India, and pre-exposure prophylaxis can also be given. The duration is usually 10 to 14 days or depends on the level of exposure till when they will be exposed. And particularly if we have an institutional outbreak, like let's say in our nursing home, ward or hospital, then all the serving healthcare workers should be given a chemoprophylaxis till that particular period of pandemicity is over. Now, it should be started as early as 48 hours within the first patient presenting to us, and 7 days is usually a safe period for which the chemoprophylaxis can be given. The antiviral drugs which can be used for chemoprophylaxis are the same. Oral oseltamivir is most commonly given. Active surveillance for additional cases should be done in community setting or if it is an outbreak in a closed setting. We should be careful, particularly that the healthcare personnel should receive antiviral chemoprophylaxis if there is unvaccinated staff, household members are affected, and an institutional outbreak over the past 14 days post-vaccination is seen. So it is the best strategy to vaccinate your staff with the current vaccine which is going on, which we will be discussing subsequently. The antiviral drugs commonly available are of various types. There are the M2 ion channel blockers, the amantadine and rimantadine, neuraminidase inhibitors, oseltamivir, zanamivir, peramivir, and lenimavir, and polymerase inhibitors, favipiravir. We have used them in the COVID epidemic also. We can see that the level of resistance to amantadine and rimantadine is widespread. It is very low, luckily, for oseltamivir, but it is a point of concern and is now being quoted more and more in several of the studies and epidemics. Now, I would like to move on to the panel discussion where you can see we have panelists from all over India, pan India, who will be discussing their experiences in the clinic, and we'll be discussing on how to manage the flu epidemic with the current and most recent guidelines. Thank you. Well, so showing that map of India, incidentally, I saw that we have covered the west coast. Only the east coast remains, but I think Kumar Bhai is east enough to give us an idea of what is going on over there. So this influenza epidemic is definitely we can see all over India. So I would like to begin this by a doctor to doctor talk, or let's say a practitioner to a practitioner talk. Dr. Anshum, way up in Gurgaon, Delhi, what are you seeing in NCR regarding this thing in your clinic?
Sir, so like you rightly pointed, everyone across the country and globe is tackling with it. And I think in Gurgaon or in Delhi NCR, as in North, we've already seen many peaks of influenza through this year. Started with peaks in Feb, March, then again around July to August, there was a peak. And I'm again seeing a rise in cases. One thing that was noticeable is that we're getting more H1N1 positive cases this time around. Whereas if we look at the peaks that were happening around March, April, patients were negative for H1N1, positive for influenza A. And from the data that was coming from the government also and across, it seemed like H3N2 was dominating at that time. But recently, there has been a surge in H1N1 cases here. There have been severe cases also, many cases getting admitted with ARDS as well.
Right. So, Doctor, I agree with you. Quite a similar presentation as to what we are seeing in central India in Indore. Dr. Kumar, in Varanasi, what are you seeing? What is the mood of influenza over there?
We are seeing there was a spurt in influenza cases, typically influenza A, and they were difficult to treat influenzas. Right, patient landed in the ICUs and were not resolving by the routine treatment we used to give, and a huge amount of oxygen dependency, a lot of mortalities were there. Mostly influenza A we had seen, not that much of H1N1 or H3N2. CT was the main basis of our diagnosis. ARDS was seen. That's how, like, it was a grim picture, not that great.
Right. So let's go down to Mangalore, and I would like to ask Vishnu Sharma sir, in your clinic, how is influenza presenting, or in your practice, to be more precise? Mute, sir. Unmute, sir.
Almost the same experience here in Mangalore also. But I felt ever since COVID, we never had a flu-free season, because almost every other day we are seeing some or other cases. I do not know whether there has been a crossbreed between the COVID and the other influenza viruses, and the virus has been more aggressive now, because we never used to see so many viral pneumonias. Ever since COVID, we are seeing increase in the number of complications, more number of viral pneumonias. I do not know whether it's awareness or something like that, but definitely what I feel is the complications have definitely taken rise.
Quite right, sir. If we go further down the west coast to the southernmost tip of India, Dr. Arjun sir, in Trivandrum, what are you seeing, sir? How is influenza going from north to south? How is it behaving?
Thank you for the question. From the perspective of Kerala, we traditionally have been seeing two peaks of influenza every year. The first peak actually coincides with the onset of monsoon in June, July. And then we have the second peak, which usually starts by November, peaks in December, Jan, and ends by February. This year, too, it has not been different. But I'd like to contradict Vishnu Sharma sir, because we have been studying influenza since 2016, in fact, for the last almost 8 to 9 years with complete data. What we find is that flu has been there even before COVID, but in some years, the strain is very aggressive. In this time, as 2017, it was like that. 2024, this year also, we find rather an aggressive strain. which leads on to ARDS, more patients going to ventilator and increasing mortality. Some years, the strain is less aggressive. So we see a lot of cases low strain, but it doesn't cause significant mortality. So that is our experience.
Quite right. So we see that across India, definitely influenza cases are very significant. In fact, the whole viral picture is constantly present. And although Dr. Arjun very categorically tells that it is still following a seasonal pattern, but I think most of us, maybe let's say till till the level of Mangalore, are actually seeing viral all the time, all the year. That is an actual reality of practice. So, but
Let me just add one more point. I do agree that the influenza activity is there throughout the year. That we see here as well. But the cases will be much less during the other periods, apart from these peaks.
Agreed, sir. Agreed. But maybe proportionately, as chest physicians, we tend to see it more. Maybe, I don't know. But you, since you're doing a proper study, that is what is recognized, and we fully respect your data set. Now, coming to Kumar Bhai, most of the yearly prevalence of influenza, Dr. Arjun has discussed. But I would like to ask you that which is the high risk population with which this influenza problem is usually seen with or is more scary?
So, thank you, boss. Influenza, like basically in young children and in elderly, less than 10 and more than 65, that is the age group that primarily gets affected by influenza. Then again, there are these high risk groups like chronic lung diseases, chronic liver diseases, chronic heart diseases, chronic kidney diseases. Anything that has chronic tag to it will have a high chance. Anything that has low immunity to it, like any immune disorders, HIV patients, AIDS patients, healthcare employees, those who are exposed to a lot of things, they have this kind of a situation where you see this increased incidence of influenza.
Hello?
Yes, sir, I'm able to hear you.
Yeah, I'm sorry. The light just went off. Sorry for that. So I agree with you. This high risk population is definitely that which we have defined and has to be looked at much more carefully than others whenever they present to us.
And healthcare employees too. Us
yeah,
also.
Us also, and our workers also, because you know everybody can get in.
टॉर्च लगा के मुंह देखते हैं ना किसी का और वो खांस देता है.
बिल्कुल सही बात है. So, Dr. Vishnu Sharma sir, tell me why is this influenza virus and what are its features, mode of spread? Why is it a problem every year and we are sitting doing webinar year after year on influenza? What is in this influenza virus?
Yeah, main thing is it is seasonal, because whenever there is a fluctuation in temperature, the spread of virus, the growth and transmission is always more. So sudden change in temperature is something which favors the virus replication as well as the transmission in closed spaces. As such, the portal of entry of the virus is through the upper respiratory tract, and most of the patients who have got viral disease, especially the viral pneumonias, will have a upper respiratory symptoms to start with. But sometimes the upper respiratory symptom may be mild in a small subset of patients where we may not be able to elicit a history. But in more than 90% of the patients, it starts with fever, body ache, malaise, and other things, as Dr. Utsav has told. And in addition, nasal symptoms, a bit of sore throat, which may vary in severity from person to person, and the conjunctival injection and so on. And most often, it is the active family member who brings the infection. Most often, when it comes to influenza, it's the children who get the infection from the schools, because the whole day they're together and they get that is how the influenza usually comes. In the family, usually if you take in history, it's the children who gets affected first and then it goes to the adults most often, or a family member who was outside, or a recent visit to a function and so on.
Quite right, sir. Quite right. Now, Dr. Anshum, tell me one thing. You have already elaborated in your opening question about the strains, but can you just tell us that this influenza, just now, which is the latest circulating strain and what are the antigenic variations over the past year or years that we have seen?
So, according to the World Health Organization, surveillance actually recently only on 29 September they had a meeting where they informed about their surveillance data for this year, and the H1N1 strain of influenza A and the H3N2 strain, the ones that I mentioned, they are the circulating influenza A strains, and in influenza B, there's a Victoria-like strain which is circulating. Now, this H1N1 strain is called PDM09 strain. This is the one that was responsible for the pandemic which happened in 2009. So, it is the same strain that is circulating. And so that has been included in recent vaccines. There were few strains like the H5N1, like Dr. Kumar mentioned, that had sporadic, reports, or the other strains like H7. So they were reported in few patients across the world, but globally, these are the predominant strains: the H1N1, the H3N2, and Victoria B strain.
Right. To make life simple, भैया influenza है. That's all.
Yeah.
That's
Yeah.
important. But Arjun sir, tell me one thing. You are the most organized and research-oriented person who has answered up till now. Is a triple epidemic present in India? Is it actually there?
It's a very good question. We are talking about Fludemic, but it is very important to understand that there is something called a Trivandrum, in which you have three important viruses which are circulating. The number one is COVID, number two is influenza, and number three is RSV. In 2022, later half of 2022, WHO had issued a warning that a triple demic is going to hit the globe. And there were few reported cases in the United States soon after that. We actually did a study last year in our own institute, and we are publishing the data in the next month's Lung India next issue, which is going to be published in November. So what we found, we analyzed all the cases that we came across last year in our institute, Kerala Institute of Health Sciences, Trivandrum. What we found is that last year, 60% of all acute viral infections we had were COVID, 30% were influenza, and 10% was RSV. And we found that, as I described earlier, we had the two peaks for influenza with sporadic cases in between. COVID significantly was having almost 2 or 3 peaks last year. But from late August, RSV started appearing in our community, in our community here. It peaked somewhere in September, October, and then waned off by December. So all three, which WHO predicted in the United States, are actually present in our country as well. So that's what.
Very important data, because still 60% COVID and 10% RSV. So very important that even now when we are seeing patients of influenza and they are not improving, we should keep our minds open. And it's not like ki, Are ye to hoga. It's not, it's Are to hoga. You have to go ahead and treat these infections also, test them. Testing is very much available now, and we should go ahead. But Dr. Vishnu, there are many people who will come to your OPD straight away. Just tell me, I have some queries in my mind. If a patient comes to the OPD, how do I suspect that that person is suffering from a viral respiratory illness? How will he present to us?
Most often the symptoms to start with will be the upper respiratory. Usually, myalgia, fever, sore throat, nasal symptoms. Sometimes the symptom may be mild, which the patient may not be able to recollect, but in a majority, more than 90% of patients, if we ask leading questions, will be able to elicit this. Second is history of contact. Most often, more than one family member will be having the similar symptom, or a close contact history is very, very important. When it comes to a serious viral disease, a complicated viral disease, which usually occurs after the third to fifth day in the majority, that is progression into the dreaded viral pneumonia or other organ involvement, they will have organ-specific symptoms. In such cases, especially, we need to differentiate this viral disease complication from other organ-specific diseases as well. The most common complication is the viral pneumonia. The symptom of viral pneumonia will be, to start with, a dry cough, a rapidly progressive breathlessness, which may progress in few hours or in a day or two. And most often, there may not be any respiratory signs, or if at all, few crepitations, fine crepitations. And the X-ray may be normal in the initial stages, but in the later stages may show ground glassing, especially in the lower zones. A CT may help whenever we suspect a early CT may help whenever we suspect a viral pneumonia. And most important is fall in saturation and exercise induced hypoxia.
Right. But at times, their friends, the bacteria also come along. So how do you differentiate a viral from a bacterial, sir?
Yeah, clinical signs to differentiate a viral pneumonia from a bacterial pneumonia is in the majority viral pneumonia, the fever is of low grade, but an occasional patient may have high grade fever. But in the majority of patients with a community acquired pneumonia, usually they present with a high grade fever, cough with a productive sputum to start with, and a pleuritic type of chest pain, and usually they will have signs of lobar consolidation. And the X-ray may show the changes. But then the problem comes a viral and a superadded bacterial infection. One of the complications of a viral pneumonia per se is viral infection per se is a increased susceptibility to bacterial pneumonia. So we need to keep in mind a viral superadded bacteria also, and laboratory investigations will help us to differentiate between a viral pneumonia from a bacterial pneumonia.
Right, right. But apart from respiratory, Arjun sir, don't you even see extra respiratory manifestations in your influenza cases? What are the extra respiratory involvements we see?
Absolutely true. We only tend to focus on the respiratory part, and often we ignore the extra respiratory, the extra pulmonary manifestations. The most important one that one should always keep in mind is the possibility of viral myocarditis, which is very important, and if it is missed, can be catastrophic. Having said that, the other cardiovascular complications or manifestations also actually include coronary artery disease, which has been very clearly documented in many studies that in the first 3 to 5 days of an influenza infection, the risk of getting a coronary artery event is almost 6 times higher than normal population. And this is true with the case of stroke as well. Then there are a lot of neurological complications, which basically are viral encephalitis, influenza-associated encephalitis. We can also have Parkinsonism-like syndrome, and even Guillain-Barré syndrome is very commonly, although it's a rare thing, it's been reported with influenza. Musculoskeletal complications are also present. The most common one is myalgia, although in severe cases, you can also very rarely sometimes see rhabdomyolysis as well. Ocular complications, starting from simple conjunctivitis, you can also go up to developing optic neuritis. I can have acute kidney injury, AKI, and acute glomerulonephritis. Then it can produce transaminitis as part of liver involvement. And hematological complications, especially thromboembolic disease, which we often associate with COVID, can also be rarely found in patients with having severe influenza, as well as hemophagocytic syndrome. So all this we should always keep in mind. These are all possible.
Quite right. Means once the patient is in the ICU, he's not improving. Then I think all of these conditions which Dr. P Arjun has enumerated, particularly the hemophagocytic syndrome, the myocarditis part, and even the neurological involvement in the form of encephalitis, they tend to complicate and confuse the picture very much. So it is very important that if our patient of influenza is not improving, let's go ahead and think apart from the lung also. You might really get a big answer there and help your patient to a great end. Dr. Vishnu Sharma sir has already told us that doing a CT scan, doing basic tests, clinical examination is most important for diagnosing primarily your influenza case. But Anshum, tell me, there is this thing, throat swab. What is throat swab for influenza diagnosis? How does it help?
So, throat swab is the preferred diagnostic test that we employ for most of the viral illnesses. Even in COVID, we would rely on throat swab, RT-PCR testing. So, throat swab is basically a method of taking sample through a swab or a tip applicator, which can be sent for virological test, for PCR testing. So basically, in case of both COVID as well as for influenza samples, we prefer to take nylon or polyester or Dacron tipped swabs, which usually have a plastic handle or a shaft, and these are used to take samples from the nasopharynx or the nasal mucosa and oral passage. So here again, a preferred approach is nasopharyngeal and oral. we have to make sure that the swab is inserted through the floor of the nose, the nasopharynx, and it has to touch the posterior wall of the pharynx. We prefer, we should always have few seconds of delay where the swab has to be kept there, and with the rotating motion slowly it should be gradually withdrawn. A nasal sample also works very well, especially in children. If you're not able to take a nasopharyngeal swab, then in both nostrils it's preferred to take different swabs, and an oral sample which can have, again, using the posterior pharyngeal wall and the tonsillar area, that should be scrubbed gently, and then these have to be transported in a viral transport medium immediately, and just like in COVID sample, so it has to be a 3-layered packaging, where you will not want to expose the sample directly to the ice pack, so it should be transmitted to lab at around 4 to 8 degree temperature, and should be processed as soon as possible.
Right. So, but you told it very methodically, and it sounds so nice if somebody goes by that protocol. But you go in an ICU, patient getting really in respiratory failure, and the intensivist or the physician is shouting on the top of his voice, "भैया जल्दी swab लो, मुझे इसको दवाई खिलानी है." तो, so tell me, in ICU, these viral pneumonia patients, can they end up in ARDS also? Can we diagnose that also?
Absolutely. So we can also, instead of the throat swab, we can use other samples, other sites. So if your patient is ventilated, you can use the ET aspirates. You can use the bronchoalveolar lavage, and they can also be sent for sampling. So in a patient who's already on ventilator, it becomes actually easy. You can send 3 to 5 ml of the ET aspirate or lavage fluid and can also process that for sampling. But again, diagnosis depends on a good sample. So if it's say a patient who's more well preserved, a right sample will be able to give us a right result. Otherwise, there may be a lot of false negatives, and we may confuse the entire picture. So again, one thing with this sampling is, nowadays I've seen that after COVID, everybody has become really lax about everything else. So if it's about influenza, the technician will also not wear protective equipment, will not take any care, and they'll just take the sample. So again, that also has to be asserted. It's still disease which is very contagious. All the personal protective equipment should be worn, and in the right way, the medium it should be transported. That's also very important. In fact, I recently got a call from one of my colleague who was managing an ICU, and she said somebody has influenza H1N1 positive, but the ICU team is not ready to give him an isolation room. They said, "Madam, COVID में देते थे, अब कोई नहीं चलता है, it'll be, we have given him a separate space." So we have to be careful. We can't be lax about it.
But that is the careful part only I would like to stress on, and I would like to call Dr. Kumar Utsav for answering this question, that there are several patients who will present in a very, very severe respiratory failure with ARDS. How do we go about managing or diagnosing them, Dr. Utsav?
So most of the task has been done by Arjun sir and Anshuman madam about going about the case, and sir, also Vishnu sir. So what you're asking me is something which we do every single day. Everybody who's listening to this lecture is managing ARDS, right? So first of all, the patient comes with tachypnea. There is increased breathing effort. Cyanosis may, or central or peripheral cyanosis may or may not be present. Altered mentation is present. On auscultation, you may or may not find bilateral basal crepitations. Again, this is of acute onset, and lung infiltrates may be present on X-ray or CT scan. We can see the PaO2 FiO2 ratio we see on ABG also, and if it is less than 300, we can diagnose it as ARDS. That's how. Then we go on to to mild, moderate, severe, less than 150, 250, and that's how we divide it, right? So that I think is enough for this discussion.
I agree with you. And even the new criteria of this saturation with FiO2 ratio is done, which as per the new which makes it more simpler. So I agree with you as that all of us are managing these cases of either in OPD presentation, IPD presentation, or in the critical care setting. But Dr. Arjun sir, what are the most widely used antivirals? Could you just mention them for the benefit of our audience?
The one that is most commonly used, as was mentioned earlier, is oseltamivir. use it at a dose of 75 milligrams twice daily for 5 days. Previously, there was a concept of giving a prophylaxis dose of 75 milligram once daily for 10 days, which we never do. We never give prophylaxis treatment, but if the patient develops symptoms, we treat it. There was also a concept of giving a high dose oseltamivir 150 milligram twice daily for 5 to 10 days, which again we do not follow. So that is as simple as that, oseltamivir 75 milligram twice daily. The other drug which is available in certain parts of our country is zanamivir. I do not have any personal experience of using that, but it is a drug in an inhalation form. The other drugs are peramivir and beloxanivir. So these are the drugs which are available. All of them are neuraminidase inhibitors. Previously, amantadine and imantadine were used, but we now know that our influenza strains are all resistant to that, so they do not work anymore.
Right. So I am very not glad but rather sad that you mentioned these adamantines. So I was actually going to ask Kumar about it, but you have already introduced this. So now I have a sad story, and that sad story is of rising antiviral resistance. There has been this IRIS study on influenza resistance internationally from 2008 to 2013, and it showed that now initially oseltamivir level of resistance was very low, but as time is progressing and as per the latest 2023 data, the oseltamivir resistance is around 3.5% and zanamivir resistance is around 1%. Now 3.5% in a country like India is very significant. Only important thing that we need to understand is, like you told, amantadines are obsolete. Now nobody knows that these drugs were even used in influenza setting. Their resistance has destroyed their potency totally. So we have to use oseltamivir judiciously and for a proper period of time. If there is a low neuraminidase resistance in the society, oseltamivir remains the drug of choice. But if there is a high neuraminidase resistance, then zanamivir is recommended. So that is what is the official word on antiviral resistance. But again, Dr. Anshum, there is one wonder drug which I know that you know of, which is recommended in antiviral resistance. Which is that drug?
So there is a new drug which comes by the trade name of Zoluza. Actually baloxavir. Baloxavir marboxil is actually the active form of it, which has been approved in US and 27 other countries, in fact, including Japan, Switzerland, and many European countries also, which is a one single dose drug, one oral dose, and it has been approved above 5 years of age. And they claim that this drug has activity even against oseltamivir resistant strains and even avian influenza strains also. So this drug is marketed by Roche. It's available worldwide. They also they have supportive data behind its use, but they say that you can use it in uncomplicated influenza or high risk patients where that they can get complicated as a single dose, 20, 40, 80 milligram dosages. As of April 2024, Roche had approached the Drug Controller General of India to approve this drug as an expedited approval, and they had actually asked that the phase 3 trial should be waived off and this drug should be included in the market, but that was not approved. So it's still not here, but they are trying, and I'm sure it will be coming up in the future.
Right. And till these guys get their approval, I would like to remember that very interesting drug which we used to prescribe in COVID times, the Favipravir, जिसमें हम बहुत सारी गोलियां पेशेंट
खिलाते रहते थे बस
खिलाते रहते थे and वो बेचारे खाते भी रहते थे. Then that is also one of the drug recommended in antiviral resistance of influenza.
Yes.
Now, I am the busiest practitioner amongst all of us is Dr. Vishnu Sharma sir. So I am keeping all the practical questions for him. So most practical question which everybody wants to hear, sir, do we give steroids in cases of influenza or not? Please.
As per the guidelines, steroids are not advocated in influenza because unnecessary or overdosing of the steroids will do more harm than good.
Right. So
because influenza virus, one of the complications of influenza viral infection is superadded bacterial infection. Anyone who gets a flu is at a higher risk to develop a bacterial pneumonia. If you look at the lobar pneumonia, most often the preceding illness is a viral upper respiratory illness, which we should not forget, because the viral infection predisposes to a bacterial pneumonia because of many neurological ways as well. So steroid always should be avoided, and
Right.
it will unmask the infection also. A serious bacterial infection, the symptoms will be will be masked.
ट्रूली सर वेरी वेल स्पोकन एंड देते तो सभी हैं बट गाइडलाइन मानती नहीं है. Again, the guideline puts in a very small word. It can be given for specific indications. So I searched the Cochrane. What does Cochrane review say about it? So the specific indications it allows for are refractory hypoxemia, hypotension in a septic shock setting. Or, when at the clinician discretion is also an important part of that review. So it's not wrong, but as per guideline, like Dr. Vishnu Sharma sir has very well highlighted, that we should try to avoid as far as possible. Only with a specific indication, steroids may be used, but definitely not when you are suspecting something else. So prevention has always been better than cure. And when we come to prevention, this is one area where really work has been done very strongly. And I would like to call upon Dr. Anshum and I'll even ask a word कि जो भी अंशुम भूल जाए वो उत्सव भाई को बताना है कि अंशुम, what are the various type of vaccines available?
Okay, so I think influenza vaccines have been the most widely available amongst adult vaccines. So we've had mostly inactivated influenza vaccine available in India. There are inactivated and live influenza vaccines. Both live vaccines were also produced in India actually by Serum Institute of India at one point of time, but could not see the light of the day because they didn't see too much efficacy. Although they were efficient, but they did not see too much response which could favor it. So inactivated is the one that is most common. Now, inactivated vaccines can be whole inactivated virus. We don't have too many of this kind in India, where the whole virus will be inactivated and through cidal agents and will be introduced wholesome. The other two forms are either you give a split virion inactivated vaccine or subunit vaccine. So split virion, the name only tells split the virion. So split the capsule of the virus, take out everything from the virus. So the hemagglutinin, neuraminidase, hemagglutinin, neuraminidase, matrix metalloprotein, the viral RNA, everything is extracted. You purify and take out the components that are not needed, like the viral RNA and others, and you take only what is immunogenic. So hemagglutinin, neuraminidase, matrix metalloproteins, and other antigenic material is taken and that is injected. These are the inactivated split virion. And one is a subunit vaccine where one subunit. So think of it as a split virion which is further purified, and then only hemagglutinin, neuraminidase, and so only the components which are highly antigenic are taken by either recombinant technique in the labs or by using cell cultures, where again it will be introduced in the chicken's egg embryo and you would purify. So these are the kinds available. Most of them we have in India are split virion. We also have subunit vaccines which are available, or both are inactivated.
So, Madam Anshuman, Madam has covered it beautifully. I don't need to add anything to it. Just one point, that there are most of the things we get in our hand are trivalent vaccines. These are inactivated vaccines with 2 strains of A and 1 strain of B. The quadrivalent is the same as trivalent vaccine, except that it has 2 strains of A with 2 strains of B. That's what it is. Rest everything which Madam has said is absolutely correct.
Bilkul. And that is why, Anshum is national DNB topper, and now I understand why. She told it in such a
ऐसे लोग टॉपर नहीं बनते हैं बॉस. देखिए मैडम ऐसे नहीं बनते. You have to have a special edge to it.
हाँ, people like us are, yeah, but people like us are happy कि marketing वाले easy नाम रख देते हैं, because ये मेरे लिए याद रखना तो impossible है actually. But still, tell me, Kumar sir, now that I have you on the topic, Indians में northern hemisphere या southern hemisphere, anything in particular you would like to point to vaccine?
ये ना एक study अपना surveillance हुआ था इंडिया का, done by some Indian authority, and we found out that हम लोग जो है we can use both the strains, the northern hemisphere strain also of 2022 and 2023, and the southern hemisphere 2022 composition, both can be used in the Indian population. So there is no problem in using. अगर कोई आता है कि SH यूज करना है, सर ये SH दे दिया या NH दे दिया, आप दोनों यूज कर सकते हो. Just make sure of the year is 2022 and 2023. That's it.
Right. So that makes
Can I add to that?
Yeah, sure.
Please.
So he's absolutely right, Dr. Kumar, that actually India falls into the northern, geographically into northern latitude. So 30 degrees north mein alag hai, and below is different weather, different seasons. So we can use both. But I was also reading about it, and there's actually a big paradox, because when you look at the WHO's description of vaccine surveillance, they always count India in the southern hemisphere. So recently also, when they spoke about new southern hemisphere vaccine, they mentioned India and the data from India and recommendation from India. And if you look at the government of India's website on influenza vaccine, they also say if you have southern, you preferably give southern, otherwise you give northern. So I think even the authorities have created this paradox. Dr. Arjun.
Can I add a word here? It's
Yeah.
not a paradox actually, because we have something called an influenza equator.
Mm.
And India falls to the southern part of the influenza equator. That is the reason why it happens.
Sorry, could you repeat it, Dr. Arjun?
There is something called an influenza equator, which is almost about 30 degrees north latitude.
Yes, yes.
So anything which falls below that is considered to be southern hemisphere as per the influenza calculations. That is the risk.
So then that would preclude.
I want to add a fun fact, Ravi bhai.
हाँ बिल्कुल बिल्कुल.
देखिए ये जो दो टॉपर हमारे साथ है ना, अर्जुन सर और अंशुमन मैडम, इन लोगों को एकदम डिटेल में जाना है, और मैं बैक बेंचर हूँ, तो मेरे को हमेशा उसी तरह की, मेरे को प्रोसेस चीजें चाहिए. हमारे यहाँ दोनों तरह की वैक्सीन लग सकती है.
भैया हम तो
आप
लोग जो भी रहो, हम तो आउटस्टैंडिंग वाले हैं, इसलिए हम मॉडरेटर बन जाते हैं. वी आर द मॉडरेटर. So tell me, Dr.
Add something more, Dr. Ravi.
Yeah, I will, sir. I also want to know. I really am looking forward to what you want to add. But I would also like to ask you that why are we pushing back to trivalent, which Utsav had mentioned just now? Please go ahead.
I will actually answer this later, but let me just add to what was asked earlier. See, actually, ICMR has a guideline as whether the northern hemisphere or southern hemisphere vaccine has to be given in the country. If you actually look into it, see, basically it all depends when the peaks happen. For example, in Kerala, as I said, the biggest peak happens in monsoon. So it becomes more prudent to give the SH vaccine in this part. In the northern part of the country, where most of the cases we usually see in winter. So it becomes more prudent to give the NH vaccine there. So that is, if you have your own data, you can actually try to find out where the peak happens and vaccinate the people just before the peak. So that is one thing. Secondly, the question which you asked, if you actually recall what Anshum said, so about the currently circulating strains of the virus, he's mentioned about 2 strains of influenza A, and 1 strain of B, that is the Victoria lineage. We all have quadrivalent vaccines, which have 2 influenza A strains and 2 B strains. The B strains which we have are Victoria and M data. So what has been observed since the COVID pandemic happened and since people started wearing the mask is that the Yamagata strain has actually disappeared from the globe. Now we only have the influenza B Victoria strain. So if we keep on giving Yamagata again as a quadrivalent vaccine, there is always a risk that we might produce vaccine-induced influenza and we might reintroduce Yamagata into the society, into the circulation. So to prevent that, now because Yamagata has been eradicated from the globe, WHO is strongly advocating to go back to a trivalent vaccine where you have 2 strains of A and the Victoria lineage of B. So that is why the impetus is perhaps from next year onwards, we'll be getting only the trivalent in our country.
Okay, so this is some very, very important point, that vaccine-induced influenza, that is why quadrivalent to trivalent. It is so important that now we also, while prescribing in our OPDs, be very careful of what we are prescribing, because this is a universal effort. Humanity has to get together to prevent the comeback of Yamagata. So please be careful about this point. Now, Dr. Anshum, we have 923 people who really want to go out and play Garba, but they are waiting for you to answer one question. We have 923 logins to our webinar, so big round of applause to all of you. Tell me, Dr. Anshum, what is this role of high-dose influenza vaccine? Well, tell me, throw some light upon it.
So, the high dose influenza vaccine means the routine influenza vaccines where the dose of HA antigen will be high. So, 4 times more than what you have for a standard vaccine. It is available in US, Europe. It's available across. It's not available in India. Number one, it has been advised even by the ICS guidelines that if whenever it is available, we could use it in India, but the population where it is given all across the globe is people more than 65 years of age who are at risk of complicated influenza. So they give the high dose. So if so, the normal standard dose has HA as 15 micro, and this one will have 60. So a higher HA. So they say that it will give more immunity. It will have lower. It will cause lower hospitalization in elderly, and it will also prevent severe disease in elderly because we want better protection for elderly. So high dose vaccines can be given in them. So this is that vaccine.
Okay, so matlab
Can
the
I add one point here as well?
please, sir,
Sorry.
please, sir.
The basic thing, as Anshum has very rightly said, is that the concept of high dose vaccine is to improve the immunity, to prevent the waning of immunity, especially in the elderly population more than 65 years of age. What basically we give is you give 0.75 ml. Normally, our vaccine contains 0.5 ml. This contains actually 0.75 ml.
Okay. So, but I will like to call in Dr. Vishnu Sharma sir to answer a very important doubt of mine. These people are talking about high dose vaccine. Sir, do these vaccines cause side effects also? Do I have to be worried about them also?
Most often, no, because the serious side effects with the vaccine are very less. But it can cause the injection site redness, soreness, pain, and all that, a little bit of myalgia and a mild influenza-like illness. But rarely, any vaccine can cause anaphylaxis. That's why whenever we give a vaccine, we advocate the patient to stay back at least for a half an hour and observe. That is mandatory. And rarely neurological complications have been described like Guillain-Barré or demyelinating neuropathy, but the incidence is very rare. But then whenever we advocate a vaccine, it's essential that we take a proper history and see whether the patient is fit to be vaccinated, because before giving a vaccine, it's an IM vaccine. So all the bleeding diathesis, patient should not have any bleeding diathesis. That's first thing. And any gross immunosuppressive conditions underlying malignancy and patients on immunosuppressive conditions, better not to give the vaccine.
Right. Quite rightly told.
Can I add one point here?
Well, definitely, sir. Definitely.
Sorry. See, as Dr. Vishnu Sharma has rightly said, he has enumerated the complications. Very important to keep in mind that these complications are much more with the live attenuated vaccine. So it's very important as far as possible not to give the live vaccine at all, especially because it can produce serious neurological complications. As far as possible, stick on to the killed inactivated vaccine.
Right. So
high dose vaccine also has slightly higher side effects than the standard dose.
No, definitely. This is very important, and I think we need to talk not only about the treatment, but also while advocating vaccination, we need to at least make our patients aware that there can be potential side effects and know themselves ourselves also. That is also very important. So I think we have discussed quite a lot, and I would just like to I'd just like to ask for a take-home message from all of you. We'll go reverse this time, and we'll go start from Dr. Arjun sir, and we'll see what is his take-home message for all our 923 listeners.
My single take-home message is you should actively campaign for influenza vaccine. Make sure that all your eligible patients get vaccinated. Don't bother whether it's a northern NH or SH strain. At least at some point in time, every year, the patient should get the vaccine.
Very right. Very simply put, but a very, very strong point conveyed. Dr. Vishnu Sharma sir, your take-home message, please.
Yeah, prevention is better than cure. So T-cell immunity plays an important role in the viral diseases. So always keep your T-cell immunity high. That is with the proper nutrition, sleep, and both physical and mental health. If it is proper, the chance of getting a viral illness is very less. So regular physical exercise is the key to keep away from viral illnesses.
Very right. Now, I would just like to tell you, we had one colleague of ours, Dr. Srikar Darisetty, who was about to join us, and he couldn't join us, but we wish him good health, and when whatever he is busy with, let him be well. But there are a few queries. Dr. Kumar और Dr. Anshum मैं आपको इतनी आसानी से टेक होम मैसेज नहीं बोलने दूंगा. First, you have to answer a few queries. First query from Dr. Pooja from Madhya Pradesh, my own state, is how to protect from this infection for kids. Any special protection for kids, Dr. Kumar?
Yes, sir. First is avoidance in crowded places, right? Social distancing, isolation of a sick child from other children. I know that is not possible. Wearing masks when in public. If you are infected, also, if you are going out in a public space, yes, masks are a reality, and we should use it more and more.
Okay. So,
Can I add a point here?
Please, sir. Please.
Upper respiratory symptoms, no further questions. Complete physical rest and keep away from crowded places. Kids should be given holiday without asking for any proof.
Right. But
may I also add one thing, Dr. Dev?
Definitely, sir. Please.
Vaccination again for children.
Vaccination again for children. Yes, very nice.
Vaccination is definitely a part of the program. Yes, of course. But yes, we have to be realistic. How many kids do actually get it? A lot of kids do, but the realistic approach should be like, vaccination is definitely the most important thing. A realistic approach is कि प्रिवेंशन करना है. घर में एक बच्चा स्कूल जा रहा है तो वो बीमार होना ही होना है. आप कितना भी सर पीट लोगे वो बीमार होगा. दूसरे बच्चे को उससे बचाना है. I am facing it every day in my house, a 5-year-old child and a 6-month-old child with me in the house. So these kind of things happen. The prevention is the best possible way.
Right, I agree with you. But one very important query has been asked by one of our doctors is there any role of IVIG in severe influenza? Particularly, why I'm asking this in relation to children is that pediatricians tend to use IVIG and immunoglobulin therapy very commonly in severe pneumonia. I would just like a word from the house. What are your opinions? I myself have given the presentation in which the guidelines don't recommend the use of immunoglobulins in influenza. So any word from it, Dr. Arjun sir, Dr. Anshum, anything about IVIG?
I also think there's no role for IVIG.
There is no role for IVIG. Right. At least in adults,
anything goes in critical patients. Anything goes. Especially in children, IVIG has been explored and has been used, though the cost-benefit analysis does not allow it to be used frequently in adults.
Right.
Sometimes we use when they have all the options have been exhausted as a salvage, but there is no role actually.
Right. Now, Dr. Vishnu Sharma, sir, you had explained us how we will differentiate pneumonia from pneumonia etiology-wise. There is a query that our colleagues are seeing a lot of young patients with perihilar opacities in influenza similar to pulmonary edema, but they are also showing effusions. So, are effusions a feature of viral pneumonia, sir?
Usually not, because two things which are less likely in viral pneumonia is a pleural effusion. Second is cavitation. So whenever we see an effusion, we need to think of other causes for a pleural effusion. It may be a complicated with a superadded bacterial infection, or there may be some other cause for pleural effusion. Like in the elderly, especially underlying heart disease, cardiac failure has to be thought of with the perihilar opacities.
I had discussed extra respiratory manifestations with Arjun sir. Dr. Shivani Swami ma'am from Rajasthan, from Jaipur, asks us that does influenza, is it known to cause new onset arthritis also?
It actually, so can I answer that?
Yeah, please.
Actually, there are a lot of patients who even after an influenza illness do complain of arthritic pains. And in fact, I had also come across a patient who was continuously complaining and there was no other thing except a recent viral URI. So I had seen some data around it sometime back, and I had noticed that there are reports actually of influenza-induced arthritis, but they say it's more common in people who already have rheumatoid arthritis and on the backdrop, and then they'll have, because it's actually an inflammatory disease again, so you will have those manifestations. It's actually possible, and it
actually,
is
also also one point of molecular mimicry done by influenza that can present itself in multiple ways and multiple symptoms can come out of it.
Right. So definitely, but even like I don't know about other places, but chikungunya is also coming up. So maybe you get that biofire panel done, or you get that tropical fever panel done, and you might throw up surprises with one or two co-infections also when arthritis is seen. Now, coming to some other questions, I would just like to take some more of all my panelists' time. Is we have discussed already regarding the use of steroids in ARDS, which will be indication based, which was a question from Dr. Arun from Andhra Pradesh. Dr. Syed Arif Hussain, my friend from Gulbarga, Karnataka, he asked that what is the role of alternate medicine, which is more tradition in our country? I think Arif Bhai has asked a question which is a webinar in itself. So anybody would like to comment on alternative medicine? Utsav Bhai.
Definitely, alternate medicine has a role in management of this common cold cough, and lots of Indians, let's accept it, first turn to the alternate medicine, and when they are not relieved, come to us. That is the fact in our part of the country, at least.
Right. And not only in your part, I think everywhere, not only in India, Indians are made famous for that, but all over the world, people are preferring these things. Now, one very interesting thing I had
ये
found
एक
in
नोशन होता है कि साइड इफेक्ट नहीं होता भाई, किसी भी चीज जिसका इफेक्ट होता है उसका साइड इफेक्ट भी होता है, बस उसका साइड इफेक्ट आपको पता नहीं है. इसका ये मतलब नहीं कि साइड इफेक्ट नहीं होता, बट लेट आई जस्ट गिव दिस वन टू देम that okay fine, you are the first one to treat it.
But one thing is that in the Cochrane review, they mention that probiotics are one group of medicines, though they are not alternative medicines, but they are not antiviral per se. But probiotics have been known to help fight the viral severity. So, and it has been proven in a Cochrane review that they have good efficacy in helping bring down the severity in mild to moderate cases. So now moving on to one more important question from Dr. Tony Luke from Kerala is that children suffering from influenza have severe night cough, which is not settling with inhaled steroids, and they need cough suppressants, particularly children less than 5 years. So any word from the house, anything that we can discuss on this and make it more easy to manage?
I think majority are sinusitis and postnasal drip. And we need patience, persistence. We need to make sure they do saline nasal washes and all that, because majority nighttime cough in children after a viral infection is coming from postnasal drip.
Right. And even
Agree to it, ma'am. Agree to it.
And what Dr. Arjun sir has told, that you need to think about other viruses also, like RSV might also be there. Just have a look at that also. One quick addition to her question of Dr. Shivani is that she is referring to arthritis post-flu vaccine. So I have a lot of trained vaccine experts over here. Any notion of arthritis after vaccine?
I have not seen a single case so far.
Not sure. I haven't.
So maybe Rajasthan ki taraf,
during not I cannot say after flu vaccine, but I had a shot of Prevenar after during the NAPCON Varanasi, because they had installed a stall over here for free Prevenar shots in Varanasi conference, NAPCON conference we did, and I had landed up in a fever with joint pain and everything exactly 2 days after it. So not I cannot comment upon flu, but I had after Prevenar. This is personal.
तो चलेगा. A good thing कि बच के रहना भैया, जो भी स्टॉल पे वैक्सीन दे उससे, तो you don't know what is there. So my point is, I think we have covered influenza in the most comprehensive manner, and in a manner which will help us definitely in our practice, both for helping our patients in preventing the disease as well as in taking care of their symptoms and treating them in a more effective way. I would like to thank all my panelists who have given their time. I would like to thank all those Garba enthusiasts who have stayed back and listened to our webinar in Navratri time also. I would like to thank each and everyone who has joined us for this very important update on the influenza endemic. And I would like to wish from the behalf and platform of CCI a very good night to all of you. Thank you.
Thank you, sir.
To
Thank
the
you.
moderator.
Excellent discussion.
Thank you, Dr. Dosi.